Hello and welcome. We bring you back Dr. Garcia again. He has been in news with us for a while now. Dr. Garcia, welcome and congratulations for your latest publication of non-invasive mechanical ventilation and nasal cannula oxygenation in COVID-19 patient. Welcome to our show again.
Thank you for having me.
For those who have not heard you, and I don't know why, because we had you multiple times now, please quickly introduce yourself for our audience.
So I'm Mike Garcia. I'm a former Boston University fellow, and I'm currently an intensivist at Valley Medical Center in Washington State. So thanks again for having me.
Absolutely, and congratulations. It has become a habit now. The latest publication, it came this month, in the month of September, at the time of the recording for this video. So tell us a little bit about your manuscript, like for laymen, what they should take out from it and how you did it.
Sure. So the manuscript is a variation in use of high flow nasal cannula and non-invasive ventilation among patients with COVID-19. And essentially, critical care guidelines recommended use of high flow nasal cannula and non-invasive ventilation, such as BiPAP or CPAP for hypoxemic respiratory failure secondary to COVID. But concerns surrounding aerosolization of viral particles and patient self-inflicted lung injury, may have limited use during the pandemic. So we sought to kind of describe the variation in use of high flow nasal cannula and non-invasive ventilation for management of COVID-19. So we did an observational study of adults hospitalized with COVID who received supplemental oxygen between February 15th of 2020 and April 12th of 2021 across 102 hospitals in the US and abroad using the VIRUS Registry. And we looked at associations of high flow nasal cannula and NIV with clinical outcomes such as, progression to invasive mechanical ventilation and mortality, using random effects logistic regression models and quantifying variation using the interclass correlation coefficient and the median odds ratio, which is the median increase in odds of a patient receiving high flow nasal cannula or non-invasive ventilation when, moving from a low use hospital to a higher use hospital. And we identified, over 13,000 patients with COVID who were receiving supplemental oxygen. And just kind of the overall breakdown, 60% of those patients received, nasal cannula or face mask only. 21% received high flow nasal cannula, 7% received non-invasive ventilation, and 12% received both high flow nasal cannula and non-invasive ventilation at some point during their hospitalization. And 27% of those patients ultimately progressed to needing invasive mechanical ventilation. We saw, very wide variation in the use of each of these oxygen modalities. So hospital site alone contributed to 24% of the variation in high flow nasal cannula use and 30% of the non-invasive ventilation use. And median odds ratios for high flow nasal cannula was 2.6 and for non-invasive ventilation was 3.1. So, depending on which hospital you were at, you had, very different odds of receiving high flow nasal cannula or non-invasive ventilation for the same condition, essentially. And ultimately, we didn't find any association with use of high flow nasal cannula or NIV with patient mortality as well.
So there's no difference, but it's a lot of data. And then for those who are not familiar with ICU level of care, same patient can utilize multiple modalities throughout their stay, or sometimes they don't go beyond certain, like just a high flow nasal cannula and they stop there, or sometimes they just need NIV, or sometimes they progress to full-blown mechanical ventilation and then step up and become better with non-invasive part of it. How you dealt with the data, or what were the barriers as you were planning the study? Because it's a lot of complicated data and it requires a careful planning, because you can very well misinterpret the results or the data points.
Sure, definitely. So one of the bigger barriers was, determining kind of timing of each of these modalities and duration of use. That's not something, that's very granular data that's kind of hard to get in any type of database. So, just with those limitations in mind, we just kind of mainly looked at, did they receive this modality and what, did they end up needing progression to invasive mechanical ventilation, or did they have increased, risk of mortality, which we didn't see within our study. So that timing and duration of each of those modalities was a little bit difficult to parse out, and one of the limitations of the study, definitely.
Okay. Let's say that you have granular data. That means you have every single day's data, and then when they have started, when they stop, and all those things. What would be your ideal research question? Or let's say, what is the next step? Let's say if we get to those granular data for the collaboration with virus, cure ID, and other things as well. What would be your ideal question to ask for?
So I think the ultimate, question that we search to answer is when is the optimal time to intubate patients with COVID-19? Because there's, theoretical concerns about patient like self-inflicted lung injury. Patients who are working harder to breathe, are they causing more lung injury? So some, clinicians would opt for early intubation to rest the lungs, prevent, less injury to those patients. But I think we really need to find out when is it optimal. Is early intubation better, or can these patients do okay on high levels of support on high flow nasal cannula or non-invasive ventilation, and without the need to progressing to invasive mechanical ventilation, which has its own risks, associated with it as well.
That's a good point. So let me tease a little bit right there as well. In your clinical practice, one theory of a hydrogel formation in lung. What is your opinion about in terms of early versus delayed, or early versus appropriate, or early versus later on mechanical ventilation? What has been your practice, or what has been your experience in last these 2.5 years? Or if you have something to lean back of a historical data, what has helped out in patients who are going to for pneumonia or developing ARDS and things like that? So not anything controversial, but just to see what is your opinion on that.
Yeah, I think early on in the pandemic, we were definitely, intubating earlier, patients on, 4 to 5 liters of oxygen, where if it wasn't COVID-19, we would normally escalate to high flow nasal cannula or NIV. We would, intubate them early. But then kind of later on, as more data came out on high flow nasal cannula and NIV, the low risk of aerosolization and, kind of more clinical experience with COVID, we kind of tended to allow, kind of use our normal supportive care practices that we would do, letting them go on high flow nasal cannula or NIV, and not, immediately going to invasive mechanical ventilation. And, on my clinical experience, I didn't, see that these patients, failed more often or had, higher risk of mortality than those who we intubated early per se. But I don't know, based on my experience, I think it's reasonable to trial high flow nasal cannula and non-invasive ventilation, and supported by our study that we didn't see, a difference in mortality at all.
No, that's a very good point. Very nice. Were you expecting these results when you went into the hypothesis based, or were there any surprises?
I think we were, just given concerns about viral particle aerosolization and the whole controversy around patient self-inflicted lung injury, that we would see wide variation in use of these modalities. So that wasn't too surprising, but it was surprising kind of how much it varied.
That's a main point. Very good. Working with Society of Critical Care Medicine Discovery Group is not new to you, but those who are watching you for the first time, what has been your experience, and what advice you would give it to the junior young investigators?
Working with SCCM and Discovery has been, a great experience. I think you have to kind of reach out to different organizations and try and collaborate as much as you can to get some of these efforts going, because this was a huge undertaking, and without such a large collaborative effort, I don't think any of this would have been possible.
And your advice to young?
My advice is to keep chugging along. Again, research is hard. You will face rejection. It's part of the process. It makes you a better investigator. It and I would just, keep chugging along and, ask for help, ask for advice from your seniors who, have gone through this whole process before.
Let me ask you this. I think, great example. You had, you worked hard. You have done a lot of good things, but you had your mentors at the Boston University during your fellowship and before that. So, can you share your take on mentoring in healthcare in general, how it has benefited you, or how you were able to take advantage of some of the giants you worked with?
So yeah, coming in as a fellow, a lot of the whole research world it's relatively new to you. So I leaned heavily on my mentor, and I wasn't afraid to ask questions or ask for his advice, because he's this is his career is in research, and so kind of getting his whole take and his whole perspective, and frequently asking questions is was always very helpful, kind of to learn about all the nuances related to research and this whole process of manuscript writing and collaboration with different institutions and organizations. So I wouldn't be afraid to lean on your mentors a little bit and not be afraid to ask for help, ask for advice going forward.
Yeah, and that is pretty important that people don't realize it, that we all need mentors at different part of our life, and then you were able to showcase that how you can utilize some of these things. We have asked you before in our previous interaction as well. Same question again, maybe a new fun fact. So, any fun facts you want to share to your audience you're comfortable sharing? Oh.
Fun fact. So I was in Italy in 2006 when they won the World Cup. So that was a fun experience. I was I was young, so I didn't get to enjoy the partying and the festivities as
The
much as I
soccer,
would
the
have liked
football World
to.
Cup?
Yeah, soccer World Cup, but it was pretty wild. So that was a fun experience and a fun fact. Soccer in Europe is a whole different beast than it is here in the States.
Absolutely fantastic. So we learned two fun facts about you last time. I think it was frisbee golf, and then today that you were there during the football World Cup in Italy. Well, thank you so much for your time. We really appreciate it. Good luck in your new staff consultant role, and we hope to bring you back with your further publications or other areas of importance for our viewers who are interested in mentoring in healthcare.
All right, thanks.
Take care. Bye.